So the next session, the first one of the afternoon, is a really special one because we're going to talk about related autoimmune conditions, but interspersed with the three talks are going to be patient stories. So these will be introduced. They're all recorded by Janis Arnold, who's one of our social workers who helps kids and families with celiac disease at Boston Children's Hospital. So before each speaker, you're going to hear Janis tell us about a patient case. We'll hear the talk, and then we'll get a follow-up afterwards. So I think this will be a very special setting. Maybe, however, I'll introduce our first speaker. Our first speaker is Jessica Ruiz. She is a physician in the Division of Endocrinology at Boston Children's Hospital. She has a special interest in the link between celiac disease and type 1 diabetes, and that's where she's focused some of her research. So Jessica, perhaps you should come down and we'll start to roll with the first patient story.
Sophia was a happy and vibrant 4-year-old who loved hosting tea parties with her stuffed animals, especially Bella, her rainbow unicorn. She made all her family members join the parties, even her 2 older brothers who rolled their eyes every time she asked. She always asked her mom to fill the teacups with pink lemonade to match the pink of the circus animal sprinkled cookies she served on her white tea plates. As the tea parties went on, Sophia's mom started to notice that her dainty sips of tea shifted to gulping down the liquid and quickly refilling the cup. Her brothers joked she was addicted to the sugary lemonade, but was she? Drinking too much lemonade during tea parties wasn't the only thing that seemed off. Sophia's preschool teacher reached out to her mom because she started asking for water very frequently. She was drinking her entire water bottle by 9 a.m. and refilling it multiple times during the day. She was using the bathroom several times an hour and falling asleep at the table during lunch. Mom made an appointment with the pediatrician, where they learned Sophia had lost nearly 3 pounds since her last well-child visit. Sophia's doctor ordered lab work, including a blood sugar test, hemoglobin, A1C, an autoantibodies panel, as well as a urine test. All came back indicating type 1 diabetes.
There is a well-established link between type 1 diabetes and celiac disease that was first discovered over 60 years ago. The estimated prevalence of celiac in patients with type 1 diabetes is approximately 8%, compared to about 1% in the general population. Due to the significantly higher prevalence of celiac disease in diabetes patients, many physicians recommend getting screened for celiac after a diagnosis of type 1 diabetes and vice versa.
And this is exactly what Sophia's endocrinologist did at her first appointment, even though Sophia reported no obvious symptoms of celiac disease. The test was positive. Sophia's parents felt helpless and overwhelmed. In a matter of a few weeks, they went from having few worries in the world to having a daughter with 2 autoimmune diseases, both that required major lifestyle changes. How would they manage a strict gluten-free diet on top of constant blood sugar monitoring and giving insulin? It all seemed like too much to handle. Sophia's family attended a Getting Started class at their local hospital to learn about balancing food and insulin. They studied food labels and started having Sophia try out new foods that were richer in fiber and whole grain. But as they started perusing the gluten-free aisles of the grocery store, they quickly noticed a problem with many starchy gluten-free products like bread, crackers, cereal, pasta. They were all higher in carbohydrate content than their gluten-containing counterparts and contained highly refined starches and sugars. A quick internet search told them these refined ingredients were used in gluten-free foods to mimic the mouthfeel and texture of gluten. Yikes. Now what?
Great. Thank you very much. It's nice to meet you all. As he said, I'm Jessica Ruiz. I'm a 3rd-year fellow in endocrinology at Boston Children's Hospital. And my research is interested in finding new uses for medical devices like the wearable glucose sensors you might have heard of, and specifically seeing if we can use that data to detect celiac disease earlier in our patients with type 1 diabetes. So this is an area important to me, and I'm really excited to speak to you about it today. The goals of my talk, just as he gets it loaded, are to talk a little bit about what is type 1 diabetes and some of the aspects of its clinical management. We'll discuss the link between celiac and diabetes and why it is that is higher prevalent in those two patient populations. And then some more of the aspects of this dual diagnosis that were touched on a little bit earlier in the day. Let's see if I can advance this now. Perfect. And these are my disclosures, none of which are relevant to what we'll be speaking about today. So I thought I would start with diabetes. Type 1 diabetes is the most common form of diabetes in children, but can be diagnosed at any age in the lifetime. And it is a diabetes that requires insulin replacement for survival. This is because in type 1 diabetes, what happens is the beta cells shown in yellow here on the left are the areas of your pancreas where insulin is produced. And when you develop this autoimmune type 1 diabetes, you have immune cells like the green T cells that go in and destroy those regions of the pancreas where the insulin is made, and therefore you become insulin deficient. Insulin, we like to describe as being sort of the key that unlocks certain cells in the body to be able to take in glucose, as you can see on the top right there. So when you lack insulin, you can't unlock the cells to bring in glucose into important cells like your muscle and fat cells. So you have a high amount of sugar in your bloodstream while actually sort of being in a sensed starvation state because you can't actually build up your nutrient stores. This is different from type 2 diabetes, which develops because the body is making insulin, but it can't respond to it appropriately. There's an insulin resistance that emerges, and that's not the type of diabetes we're discussing today. So when I shorten it to diabetes, I'm talking about type 1 diabetes. So we just heard a really wonderful motivation for why we're discussing diabetes here at Celiac Smarts. So the global prevalence of either celiac disease or diabetes in isolation is shown here. Celiac disease is in about 1.5% of the global population, and type 1 diabetes is in about 0.1%. In patients with, sorry, something on my screen here. In individuals with type 1 diabetes, the prevalence of celiac disease can be up to 16%, which is around an 8 times increased risk. And in individuals with celiac disease, there's also an increased risk of type 1 diabetes developing, which is quoted to be anywhere from about 2.5 to 6 times higher than the general population. So it's definitely important from my perspective as an endocrinologist and from our perspective as those caring for individuals with celiac disease to be aware of this link. It's not advancing. So I wanted to dive into the science for just a minute and talk about why this co-occurrence is so prominent. Part of it comes down to a shared genetic susceptibility between these two conditions. So there are multiple regions of our genetic code that have been identified to give a higher risk of both celiac disease and type 1 diabetes. One of these regions are called what's known as the HLA alleles. And these areas that we'll talk about comprise about half of the genetic risk for both of these conditions. The HLA region encodes something called the major histocompatibility complex, which is a mouthful. It's shown here in orange. And it's actually this region on all of our immune surveillance cells in the body. Those cells go around and they try to find things that our immune system needs to be primed against and form a response against. And so what it does is it presents things like antigens, which is the little sort of triangle shape in the middle, to promote an immune response. When this area has a genetic code that's a little bit different, sometimes it can make a mistake and instead decide to form an immune response against things like gluten or insulin or other things that kind of mimic parts of our body or things that we should be able to tolerate. And what ends up happening is our immune system creates this like incorrect immune response against those things, which can lead to celiac disease or type 1 diabetes, or if it's mutated in just the right way, a risk of both. There are also many other genes that have been identified outside of this biology I was just describing that also give an increased risk of both conditions that are listed here. And they also have to do with how the immune system works. There are some theories out there about how, in addition to this genetic context, there are also aspects of either celiac disease or type 1 diabetes that can give you a higher risk of developing the other. So in celiac disease, you have this damaged intestinal lining or mucosa that can increase the body's exposure to other foreign antigens, that yellow triangle that I was showing. And those antigens sometimes promote immunity against the pancreas that can lead to the development of type 1 diabetes. It's been shown that certain types of wheat protein might be associated with more aggressiveness of the immune system towards the pancreas. And some of those immune T cells we were talking about that cause pancreatic inflammation might actually come from the intestine. On the other side, in type 1 diabetes, there has also been shown to be increased intestinal permeability, which drives the immune system to kind of have more activity in that area. Which can lead to those immune cells, the T cells, to have more reactivity towards gluten and can ultimately predispose to celiac disease. So the cascading predisposition, as I called it, sort of follows in either direction. There are many other factors too that contribute to the development of both of these conditions, including other things in our environment that we're still learning about. And we think that this is true because if you look throughout the world, the prevalence of these conditions is different in different countries and different populations. And there's some question about how shared antigens like gluten could directly contribute to the development of both conditions. So there's this study that's ongoing that takes infants with a high risk of celiac and type 1 diabetes due to their genetics, and they study them to see how likely they are to develop those conditions. And it's been shown that those genetically predisposed infants have a higher risk of celiac disease with a higher amount of gluten exposure early in life, and a higher risk of type 1 diabetes if they're exposed to gluten very early in infancy. But again, this is something that is still being investigated, and there aren't any specific recommendations for infant gluten exposure at this time. So how do we look out for this in our patients? In patients with celiac disease, there are not currently any specific guidelines to screen for the emergence of type 1 diabetes according to different international consensus groups, but your providers are aware of this link and certainly would either screen or refer for screening if the development of any symptoms arises. And we were discussing over lunch actually that these guidelines might change over time because there's now a therapy that's on the market for patients 8 and older who have diabetes antibodies and some sign of blood sugar abnormalities that can prevent the onset of type 1 diabetes by about 2 years. So this is something that is an active area of investigation and conversation. In my patients with type 1 diabetes, there are specific recommendations to screen for celiac disease, as we've been discussing. So we screen all patients after they're diagnosed with type 1 diabetes, and again, within 2 and 5 years following diagnosis, or if any concerning symptoms arise, like any gastrointestinal symptoms, growth challenges, or an increased rate of low blood sugar levels. In adults, it's recommended to screen if there are any signs and symptoms of celiac disease, but not a specific timetable laid out. And it's interesting to note that most cases of celiac disease develop within the first 5 years of diabetes diagnosis, and most of those patients do not have any specific symptoms at the time of diagnosis that they have identified. I wanted to give just a quick word to what the signs and symptoms of type 1 diabetes are. So we heard about this some in the vignette that was shared with us, including things like excessive thirst, feeling excessively hungry, or unexplained weight loss. You can have changes to vision, changes to your ability to concentrate or energy levels. Sometimes we can see an increased frequency of different types of infections like yeast infections, urinary tract infections. And I often tell my patients and families at higher risk to look out for changes in urination. So waking at night to urinate frequently, or in a child who sort of was able to sleep through the night fine, now is starting to have bedwetting again, or in an individual who's diapered, having more frequent or heavier wet diapers. Any of these symptoms are a reason to talk to your primary care doctor for further testing. The management of type 1 diabetes is really centered around intensive insulin therapy, and it's our still somewhat crude attempt to mimic like the beauty of how the pancreas works when it is producing insulin normally. So generally we start by giving kind of a 1 dose of long-acting insulin every day that meets our insulin needs between meals and when we're sleeping. Then you take boluses of insulin to cover for any food or high blood sugar levels you might have and need to check blood sugar levels frequently throughout the day. You might have heard of these insulin pumps that are becoming smarter and smarter every year. They can modulate how much insulin you're getting throughout the day and actually sort of communicate directly with wearable glucose sensors. But we don't have a system that's completely hands-off yet, hopefully coming soon. So my mentor, Kate Garvey, always shows this slide when she talks about type 1 diabetes, just to represent the tightrope walk that our families and patients engage in on a day-to-day basis of balancing the risk of high blood sugar levels with the risks of low blood sugar levels and trying to just find their balance amongst their busy lives. She also loves to show this slide, which just goes through all of the different factors that can affect your blood sugar levels. And as you see here, many nutritional factors play into it, as well as celiac disease itself, which can confusingly cause either high or low blood sugar levels, adding just an extra layer of challenge in this situation. And so thinking about the gluten-free diet and celiac disease and type 1 diabetes, it has really all of the benefits that have already been discussed today, including reducing gastrointestinal symptoms, might reduce episodes of low blood sugar levels in our patients' diabetes and improve bone density, likely has some impact on growth, although sort of mixed results on like at final adult height, what the outcomes look like. And many have looked to see if it either improves or harms sort of blood sugar control on a long time scale, but overall, no significant change has been found, although some patients do need more insulin on a day-to-day basis. One aspect that was also mentioned in the vignette is what's called the glycemic index of the gluten-free diet. So many gluten-free foods have a higher glycemic index. The glycemic index is this way to quantify how much we would expect your blood sugar level to change based on food intake, where something with the low glycemic index has fewer carbohydrates and a higher proportion of things like dietary fiber, healthy fats, and protein, whereas high glycemic index tends to be more simple carbs and starches and processed foods. And we think about this a lot in diabetes because a high glycemic index leads to the red curve that you see on the screen, where you have a faster and more dramatic rise in blood sugar levels after eating. Whereas with the low glycemic index, you have a smaller glucose excursion and it's sort of flattened out and spread over a longer period of time, which is on the whole more helpful for diabetes control. Lastly, I wanted to just touch on the experience of a dual celiac and type 1 diabetes diagnosis. It's been cited that the adherence to gluten-free diet is lower in individuals with a dual diagnosis compared to celiac disease alone. And there's actually been cited a 3 times higher rate of eating disorders or disordered eating in the dual diagnosis community compared to either type 1 diabetes or celiac disease alone, which is important for us all to be aware of. In studies looking at quality of life, they found that there are some statistically lower quality of life reports in adults with the dual diagnosis compared to just diabetes, but not statistically so in children at this point in time. I think that more studies are needed, and we all recognize really the impact of a dual diagnosis on the lives of these patients and families. And I wanted to end with a few quotes, if they're large enough to read here, of 2 qualitative studies that really solicited just sort of open opinions from parents and children with a dual diagnosis about their experience. So the 2 quotes on the left discuss sort of how challenging it is to have sort of just be getting to understand what it's like to live with diabetes and then have that celiac diagnosis come on top of it, and how overwhelming that can be. As well as sort of like reaccommodating all of the different food choices that are needed to be made on a day-to-day basis. And on the right, I have 2 quotes that show that really, of the 2 diagnoses, sometimes one can kind of weigh more heavily than the other. And it's really a matter of, patient and family experience. Some families worry a lot about the impact of diabetes on long-term health. Other patients really experience celiac disease as being more burdensome of the two, given their experiences with following the gluten-free diet. So we have discussed type 1 diabetes, its management, and the link between diabetes and celiac disease. And I just wanted to thank Dr. Catherine Garvey, who's my mentor in the diabetes clinic, and Jocelyn Sylvester, who you'll hear from later today, who's been a great research mentor as a celiac disease expert, and of course, all of our inspiring patients and families. So thank you for your time.
It's been almost 4 years since Sophia was diagnosed with type 1 diabetes and celiac disease. Today, she is a thriving third grader and loves playing soccer and the piano. She uses an insulin pump and continuous glucose monitor device that measures her blood sugar with a subcutaneous glucose sensor that reports a value every 5 minutes. Her mom gets the readings on a smartphone app so she can watch over her while she's at school. Sophia's school cafeteria has worked hard to include her in the normal lunch routine and serves foods like grilled chicken, hard-boiled eggs, cheese sticks, hummus, Greek yogurt, multigrain crackers, gluten-free pretzels, and fresh cut vegetables. In her own words, "Sometimes it's really hard to be gluten-free, but I know that eating good foods will keep me strong and healthy."
Our next speaker is Amelie Therrien, who has recorded her talk for us. She is a gastroenterologist in the Celiac Center at the Beth Israel Deaconess Medical Center. In addition to her research focusing on celiac disease, she sits on the executive committee of the Harvard Medical School Research and Education Program and is also on the executive council of the Society for the Study of Celiac Disease. However, before we show her talk, we're going to start with another patient story.
The year was 1992, and all Dave wanted was to be your average college male. You know, going to classes, dating, and enjoying the typical university nightlife. But his college experience was far from that. Instead of being the life of the party, Dave found himself with frequent bloating and heartburn, and earning the nickname in his social group of, quote, Puking Dave. Dave referred to himself as a Tums addict, and by early 2005, found himself throwing up after nearly every meal. He went to the doctor and was diagnosed with acid reflux. He was given a prescription medication, but it didn't really help. He went back to the doctor and was given a motility test to track how food moved in his body. The test showed normal digestion speed and gave no answers as to why Dave couldn't eat normally.
Eosinophilic esophagitis, or EOE, is an autoimmune disease that causes inflammation and damage to the esophagus, the muscular tube that connects the mouth to the stomach. It is usually caused by a food allergy and can affect one's ability to eat, both physically and psychologically. Damaged esophageal tissue can lead to difficulty swallowing or cause foods to get stuck when you swallow. This can cause a great deal of anxiety for patients at every meal. Testing procedures for EOE can be complex, and many aspects of the diagnostic criteria aren't standardized. EOE symptoms can look a lot like those of other conditions, making a diagnosis sometimes a long road for patients.
And a long road it was for Dave. By now, Dave was so frustrated with the lack of answers he was getting from his doctor that he felt ready to give up and just try to accept that eating would never feel normal again. He lived this way until 2010, when his symptoms got worse, and he started having major difficulty swallowing and food getting stuck in his throat. He started a list and began to see a pattern of this happening whenever he ate eggs, beef, broccoli, apples, potatoes, pork, chicken, and salmon. Around the same time, Dave started getting severely constipated and experiencing numbness in his hands and feet. He had a burning sensation in his left calf and pain in his knees, hips, shoulders, and back. He was always cold, and his mind was consistently foggy.
Celiac disease can be difficult to diagnose because symptoms can vary greatly from patient to patient. Anemia, osteoporosis, loss of dental enamel, heartburn, headaches, tingling hands, joint pain, or a blistery skin rash. Among one of the hardest symptoms to pinpoint and connect to celiac disease is brain fog. Diagnosis gets even more challenging when there are multiple autoimmune diseases affecting the patient all at the same time.
In 2016, more than 20 years after symptoms started, Dave saw a new doctor and got his first diagnosis of Hashimoto autoimmune thyroid disease. He started taking levothyroxine daily, which helped his constipation and numbness in the extremities, but the heartburn, bloating, and regular vomiting did not get any better. So Dave did what any person does these days and turned to Google. With a little bit of research, he learned about the strong connection between Hashimoto's and celiac disease. Armed with his research, he returned to the doctor and asked for a celiac blood test. It was positive.
The prevalence of autoimmune thyroid disease in patients with celiac disease is 4 times greater than that in the general population and is likely due to a shared genetic predisposition. The symptoms of the two conditions overlap greatly, but the treatments are different. With celiac disease, the only treatment is a strict gluten-free diet. Hashimoto is treated with the drug levothyroxine, a synthetic hormone that works like the T4 hormone naturally produced by the thyroid. Both the gluten-free diet and levothyroxine are lifelong treatments.
Armed with his positive blood test for celiac, Dave immediately started a gluten-free diet and felt confident that paired with the levothyroxine, he was on the path to being well for the first time in decades. It took about 4 months to start noticing a difference. He says it was like, quote, someone flipped a light switch the day he woke up and his mind wasn't foggy and his heartburn and bloating subsided. He finally felt hopeful that he could lead a normal life. But despite his rigorous efforts with the gluten-free diet, he was still choking on food when he ate. So he did what he does best, started doing more research and made another appointment with his doctor. An upper endoscopy later, he had his answer, a third autoimmune disease added to the list, eosinophilic esophagitis.
The association between eosinophilic esophagitis and celiac disease is still controversial, and its prevalence is highly variable. Like celiac disease, one of the treatments for EOE is the elimination of specific food groups from the diet. But unlike celiac disease, where the known trigger is gluten, with EOE, it takes some deeper investigation. It's fair to say it's complicated.
Thank you for the invitation to present on eosinophilic esophagitis and celiac disease. I'm sad not to be able to be there with you today. Here are my disclosures. You all know and heard about celiac disease today, so let's focus on what is eosinophilic esophagitis. This is an inflammation of the esophagus, which is the tube between the mouth and the stomach. The inflammation is caused by eosinophils and is likely an allergic process towards aeroallergens and foods. Eosinophils are immune cells that are filled with little granules. They are mostly in the tissues, but also in the blood. Eosinophilic esophagitis is a rare condition in the United States, affecting about 56% per 100,000 individuals. The incidence has steadily increased since the 1990s. And as for many other autoimmune and inflammatory conditions, we do not know how long it takes before becoming symptomatic. So we may be facing an iceberg situation with lots of undiagnosed individuals. Prevalence appears to be higher in the Northeast, aka us in New England, and urban areas. In adults, males in their 20s or 30s are more commonly affected, and in children, males are also at higher risk. The disease presents with several symptoms, such as trouble swallowing solid food, regurgitations, food impaction, which means that the food gets stuck in the esophagus, does not come up, and the person may go to the hospital and have an endoscopy to remove the piece of food. Heartburn that does not improve with antacid, chest pain, upper abdominal pain. In young children, they may refuse to eat solid foods, have nausea or vomiting, or complain of belly pain. Eosinophilic esophagitis is diagnosed with an upper endoscopy like celiac disease. On the figure on the upper right, the first figure A is a normal esophagus, and the other pictures are examples of abnormal esophagus affected by the disease, and figure D is a food impaction. Biopsies of the esophagus are needed to make the diagnosis, and the pathologist will report an increased amount of eosinophils in the esophagus, which are the pink cells on the picture at the bottom right. It is also important to note that to make a diagnosis, the GI should take biopsies of both the distal end of the esophagus and the middle part of the esophagus. Seeing eosinophils in the distal part of the esophagus only does not mean that the person has eosinophilic esophagitis. There are different treatment approaches. Changes in the diet can be enough. Some people goes on a 6-food elimination diet, which removes milk, eggs, wheat, soy, nuts, and fish, and eventually reintroduce each item one at a time to identify the trigger. Some undergo allergy testing to identify specific allergies. Some are put on an elemental diet, which is pre-digested foods such as amino acids, sugars, and fat into a smoothie. Medications commonly used include proton pump inhibitors, which are antacids such as omeprazole, steroids such as fluticasone or budesonide, or in refractory cases, biologics are used. When there is a stricture in the esophagus due to the disease, we can proceed with dilatations in endoscopy. So for the rest of the talk, eosinophilic esophagitis will be referred to as EOE and celiac disease, CED. The association between celiac disease and EOE is controversial. Over the years, many small cohort studies looking back as to whether their patients with celiac disease also had EOE found between 1 and 10% of the patients with celiac disease also having EOE. These studies are mostly in children. However, looking at larger cohort, we must keep in mind that the absolute numbers are low. In this cohort from the Celiac Center at Columbia University, where they look back at all of their patients with celiac disease to see whether or not they had EOE, among 1,439 patients with celiac disease, 14 had EOE. However, considering the expected rate of the disease in the general population, which is 56 for 100,000 people, this rate is 16 times higher. Looking at the pathology database in the United States, among 1,131 patients with celiac disease, 72 had a higher count of eosinophils in their esophagus, but only 23 had symptoms of trouble swallowing, and 28 had a very high count of eosinophils, which is more suggestive of EOE. But overall, the association was mostly not statistically significant between the two diseases. Other large studies did not show an association, including a cohort from Mayo Clinic, including 10,201 children, and a Swedish study where they randomly selected people to have an endoscopy and biopsies of the esophagus and the small intestine. As such, a systematic review, which is a review of all the literature published on the subject, concluded that there is a lack of valid studies, and the current available evidence does not support an association between the two conditions. How come small studies are showing high rates of people with both conditions then? A lot of this stems in the concept of referral bias. Indeed, these cohort studies had patients with celiac disease or EOE who presented with some symptoms leading to having an endoscopy. Some of the symptoms of the two conditions overlap, notably upper abdominal pain. However, we also know that lots of people with celiac disease do not have gastrointestinal symptoms, and lots of people with celiac disease are currently not diagnosed. They do not know they have the disease. Hence, these studies did not reflect the rates of EOE in every person with celiac disease, but in celiac disease patients that have GI symptoms. Moreover, it is possible that the esophageal biopsies were performed in some cohort only among people who had visible abnormalities in the esophagus and not like with every patient. So this adds another bias. So I would also like to emphasize that when we biopsy the esophagus of people with celiac disease, we may find some eosinophils in small amounts, but these people do not develop EOE. Moreover, celiac antibodies were found in people with EOE without finding celiac disease when we biopsy their intestines. Of course, we do not have long-term follow-up data as to whether these patients will eventually develop both conditions, but 27% of the patients with EOE and positive TTG were not carrying the genes associated with celiac disease. This is also a good occasion to remind you that a small elevation of the TTG antibodies is not specific or diagnostic for celiac disease, and this is why we are still doing endoscopies and biopsies in most people to confirm the diagnosis. Thus, are there links between the two conditions? So on one end, wheat can be a trigger for EOE, and up to 25% of EOE patients improve on a gluten-free diet. Both conditions have been linked to the use of antibiotics at a young age, which could change the microbiota. And also both conditions are also seeing their incidence like increase since the 1990s. However, a study did not find more DQ2 or DQ8, which are the genes associated with celiac disease, among people with EOE, so they do not share a common genetic predisposition. Also, the immune processes are different. It is an allergic Th2 process for EOE and a Th1 process for celiac disease. And finally, a study examined people who had both condition and people with only celiac disease or only EOE, and they did not find a difference in the symptoms or biopsies. So to have both EOE and celiac disease is not a distinct disease that will be worse than having one of the conditions. I mentioned that wheat can be a trigger for both diseases, but if we look at the cytokines and cells involved in the inflammation of the two conditions, these are completely different pathways. The only thing I was thinking was whether the same gluten-specific T cells are involved in both conditions, but this has not been looked at yet in studies. So how do we do when we have both conditions? So the pediatric groups from University of Chicago examined 350 patients, of which 22 had both celiac disease and EOE. 18 were diagnosed at the same time, and 4 developed EOE after the celiac disease diagnosis. Interestingly, 7 did not have any symptoms of EOE, but were likely incidentally diagnosed because the doctor performed biopsies of the esophagus at the time of an endoscopy to diagnose celiac disease. Of the 22, 6 only did a gluten-free diet, of which 2 had a resolution of their esophagitis on repeat biopsies. The other treatment, in addition to the gluten-free diet, included dairy, nuts, egg, corn elimination, and also 6 food elimination diet. One finding of the study was that soy was usually well tolerated and not a trigger in this population. And overall, the majority of patients were controlled with only dietary changes. 7 of them had also antacids and 2 had steroids, which is the budesonide. So to summarize the question I was asked to answer, the association between the two conditions is controversial, and to date, there is no clear common pathway linking them. So in conclusion, eosinophilic esophagitis is a rare condition affecting 0.056% of the US population, but incidence is increasing. As for celiac disease, it is unknown how long the disease is present in the esophagus before becoming symptomatic. Whether there is a causal association between the disease and the celiac disease and the eosinophilic esophagitis remain controversial. We may find the latter because we are doing an endoscopy for the former. Wheat may be a trigger, but these are 2 different mechanisms involved, allergy, IgE for EOE, and a T-cell reaction for celiac disease. And I would recommend an expert review to confirm that each diagnosis is correct when both diseases are present, especially since celiac disease patients may have some eosinophils in the esophagus without having EOE, and patients with EOE may have mild elevation of the TTG without having celiac disease. So before putting someone on a more restrictive diet, it's really best to confirm both diagnoses. So I would like to thank you for your attention. I would like to thank also the American College of Gastroenterology for supporting my research, and Celiac Disease Foundation for supporting this conference. I hope you enjoy the rest of the conference. Thank you.
It's been decades since Dave began his journey to getting a diagnosis. He now lives on a strict gluten-free and dairy-free diet and feels healthy most of the time. However, he lives every day with major food anxiety issues and rarely eats outside of his home unless he's at a well-established gluten-free eatery. Dave has learned to love cooking and is having fun discovering how to modify recipes to prepare his favorite meals at home. In 2018, his sons helped him create an Instagram account to post his gluten-free recipe photos, and it's now become his hobby. In his own words, "I turned 50 last January and I feel like a new person. I don't think I knew how sick I was until I felt normal. My best advice, don't stop advocating for yourself because you might just find yourself feeling well."
We're moving on to our third set of conditions that are associated possibly with celiac disease, and that's neurological issues. And I'm very pleased to introduce Dr. Samuel Frank. Dr. Frank is a neurologist at the Beth Israel Deaconess Medical Center and associate professor of neurology at Harvard Medical School. He's a member of the Harvard Medical School Celiac Research and Education Program and is an expert in treating patients with neurological conditions related to celiac disease. So I'll call up Dr. Frank while we're listening to our third patient story. Vincent.
Vincent was an extremely active child. He grew up just outside of Boston, and his parents knew they were in for an athletic kid when he was scoring goals on the soccer field in his preschool league. At age 10, Vincent started playing on his town's competitive travel soccer team, and during the winter months, he tore up the mountains in New England on a competitive ski racing team. He was also a good student and loved reading and writing stories about his adventures in sports. He was an all-around talented kid and extremely kind too. Just after Vincent's 15th birthday, he was at a ski race in Vermont. He was waiting on his turn to race through the slalom gates when he felt a strange wave come over him. His eyes felt blurry with small flashes of light, and he felt tingling in his hands and cheeks. He clicked out of his skis and sat down on the snow. Opening his eyes sent a stabbing pain through his head, so he pulled down his goggles to block out the sun. Within a few minutes, he got what he describes as the, quote, worst headache of his life. Just moments later, his race number was called, and it was his turn to fly down the icy mountain. He did what he thought was expected of him and started the race. He made it down safely, but was disappointed with his time. He found his mom and told her he had a headache. She took Vincent into the lodge, got him some water and Excedrin, and told him to close his eyes. He did as he was told, and about an hour later, he was feeling much better. He grabbed his skis and headed back up the chairlift. He finished second that day.
A migraine is a headache that can affect both kids and adults and causes severe throbbing pain, usually directed at one side of the head. Migraine headaches can be accompanied by nausea, vomiting, and a severe sensitivity to light and sound. Attacks can last for a few hours or up to several days at a time. In some cases, migraine pain can be so intense it interferes with daily life activities. In some patients with migraines, they experience a warning sign that the headache is coming called an aura. The aura may cause visual disturbances like blind spots, flashes of light, or tingling in the extremities or face.
Vincent returned home from that weekend's ski race, hopeful that the headache he got was caused from not drinking enough water that morning. But much to his dismay, the next day and several days after, the headaches returned. Some days he got severely nauseous with the headaches and vomited. Other days he had no headaches at all, or they were less painful, or he felt better with Excedrin. This went on for months. After several spells of headaches, Vincent's mom made an appointment with the pediatrician to hopefully get some answers. The pediatrician's first impression was that Vincent was running himself ragged with 2 competitive sports teams and a demanding course load at school. His sleep was irregular, and he didn't always eat consistently throughout the day. He recommended that Vincent scale back and build in more time for rest and proper hydration. If things didn't get better in a few weeks, he would make a referral to a neurologist for additional testing. Vincent's mom gave rest about 2 weeks before she went ahead and scheduled an appointment for her son to see a neurologist. She had recently seen a webinar where experts were discussing the link between celiac disease and headaches. She herself had been diagnosed with celiac disease years ago. Despite her gastroenterologist recommending the entire family get screened, she never made the time for them all to have blood work done. She had a sneaking suspicion that gluten might be causing these headaches. She also started a food diary to see if she could link his headaches to meals from that day. Unfortunately, keeping track of everything a teenage boy ate all day while out of the house was trickier than she had imagined. Vincent's neurologist did not agree with his mom's suspicion about celiac disease. He started by ordering an MRI. It took several weeks to get the appointment, and the scan came back noting some minor changes in white matter, but nothing significant. The neurologist recommended starting Vincent on a combination of medications to knock out the headaches: the blood pressuring lowering medication verapamil and anti-seizure drug Topamax. He also prescribed sumatriptan pills to help abort the headaches when they started. He told Vincent to expect the drugs to take several weeks to take effect and to just, quote, hang in there in the meantime. Vincent reliably took the medications, but quite quickly he started thinking that the medications were making him feel sicker than the headaches. He was severely constipated and felt as though he couldn't find his words. Where he used to be sharp at school, he felt in a haze where he couldn't remember what was coming next. This went on for about 6 months before Mom called it quits and went back to the pediatrician. She demanded a blood test for celiac disease. It was positive. 1 week later, he was in to see a gastroenterologist at the local children's hospital, and a biopsy confirmed the diagnosis. Within 3 months of starting a strict gluten-free diet, Vincent felt like a new person. He vividly remembers waking up one morning and feeling like the haze was gone and he was himself again. He had weaned off all the medications and was getting back to his normal life. While Vincent felt happy and relieved, Mom felt angry. She had watched her son lose more than a year of his life, fall behind in school, and need to pull back from the competitive sports he loved. She was mad at herself for not getting him tested for celiac disease sooner, and frustrated that her concerns weren't taken seriously in the beginning.
Well, while the slides come up, I'm a neurologist, and I think it's pretty obvious why everybody else on the panel has been here, but why a neurologist? And I got involved in celiac disease actually in the late 90s when I was still training as a resident at the University of Rochester, because we learned that people with celiac can have ataxia or incoordination problems. And that's really my area of expertise is in movement disorders. So I've really been aware of this for a long time. And then 2 of my 3 daughters were diagnosed with celiac. So then, of course, I had a very personal connection as well. I don't have any disclosures. I will say that I learned something new this week, and I had to include it in my slides. I think many of us have heard of a pride of lions and gaggle of geese, but I learned that giraffes, when they're together and standing around, are called a tower. And I felt like it was such a great analogy that when people hear that celiac can cause problems in the brain and nervous system, they freeze, that they just stand there, that there's that it seems more serious than other aspects. And I hope that I can put your fears at rest with that. I think that we've talked we've mentioned some of the topics that I want to briefly discuss today in the time that I have. Brain fog, and I really want to differentiate that from dementia, because a lot of times people come to me and say, I'm not thinking right, I think I have dementia. And I think that those are 2 very different topics. So I just want to clarify that. Neuropathy, which you've heard a little bit too, in terms of the numbness or tingling that may present in some patients and is relatively common as one of the neurologic manifestations in celiac disease. Migraine as well. Epilepsy and seizures, I think, is not discussed enough, but some of the emerging literature says that perhaps we should think about it more. And as I said, ataxia or incoordination is the diagnosis that was my introduction to celiac disease. And I'm not really going to get into non-celiac gluten sensitivity, but there is some link there. And I want to emphasize a lack of links to other neurological disorders, because that comes up as well. In terms of neurology issues and celiac disease, about 10% of patients present with neurological issues and symptoms. And I think that it's reasonable for primary care doctors and GI doctors to focus on so many other issues that are going on that the neurological ones sometimes take a back seat, which I think there's enough going on that's understandable. But of course, I have a biased point of view. The first complication of neurology related to celiac disease was actually noted in 1908. So this is not a new phenomenon. And this was specifically in a peripheral nerve related issue in 2 patients. There are a number of reported neurological manifestations. I mentioned many of these under the more common aspects: brain fog, ataxia, neuropathy, restless leg syndrome as well. And this can be by itself or due to neuropathy or iron deficiency can cause restless leg syndrome, epilepsy, migraines, and depression and or anxiety. There's a long list of less common or rare disorders on the other side. I'm not going to get into these at all, but I think that there are a handful of cases of different neurological issues that can show up and occasionally are associated. Okay, so giraffes don't just have one name in terms of the groups. They have 3. And so hopefully this will start. There we go. So when giraffes start to move and they're wandering along, it's called a journey of giraffes, which I just thought is a great name. And so let me take you on this journey in terms of neurological issues in celiac disease. So brain fog is a common term. I think particularly with the pandemic, a lot of people have used this and heard this term, but it's not technically a neurological one or a medical one. It's really used to describe a set of symptoms that may interfere with thinking. People describe poor focus, word finding troubles, organizational difficulties, kind of memory troubles that aren't very specific about one thing or the other. Even more rarely, people will describe episodes of confusion or disorientation. So it means a lot of different things to different people. But not thinking right, I think, is the general umbrella. And why people get this specifically in celiac disease is not clear. It could be secondary to other nutritional deficiencies. We know, for example, when people have B12 deficiency, that can absolutely throw off thinking. Thyroid problems as well in terms of causing nutritional deficiencies. There are some studies to suggest that regional blood flow in the brain may be different in these cases. Maybe it's related to just general inflammation that we can see, or even low levels of serotonin, which is involved in the gut as well as many different processes. And we know that untreated celiac disease and associated inflammatory disorders and inflammation in celiac may interfere with neurotransmitters and impact functions of the brain outside of just the blood vessel side of things. So again, I think that this is a non-specific term, but a lot of people know what we're talking about. Unfortunately, it's really not well studied. And in the few studies that are out there really shows that once people are on a gluten-free diet, if they have more significant or severe brain fog that is under study, it may take a number of months to years for it to fully resolve. Now, I just want to emphasize again that brain fog is not dementia and is unlikely to lead to dementia. However, there are a handful of cases of dementia as a result of celiac disease. Now, keep in mind, there are 6 million people with Alzheimer's disease. I'm going to tell you one case series of 26 people. So we're talking about a very small number of people. This does not lead to Alzheimer's. I just want to be very clear about that. Usually in the 26 people that were reported to have dementia or significant cognitive impairment in the context of celiac disease, there were obvious GI symptoms at the time that were just not recognized. And that was relatively soon in terms of, or proximal in terms of when the memory issues started, within a couple of years. Again, the mechanism may be direct inflammation. It may be secondary to other nutritional deficiencies that can impact memory. Folate, B12, vitamin E deficiencies have all been identified in celiac disease and certainly are causes of cognitive issues as well. And even of the 26 cases that were diagnosed with celiac disease and presented with dementia, about half of them improved over time, which was encouraging. Moving to ataxia, again, that's the coordination, a lack of accuracy or coordination of movement. And that is not due to weakness, alteration in tone, loss of position sense, or the presence of involuntary movements. And this is when you're reaching for a glass and you knock it over, or you're dropping things, or you're dancing on the carpet and you trip over nothing at all and fall. These are the types of things that can be a sign of ataxia. It doesn't mean that everyone has ataxia, but in more significant cases, you can pick it up on neurological examination. And this is one of the well-known complications in celiac disease. This was actually first reported in 1966. So again, not a new phenomenon in celiac disease. It's possible that in some patients, it was due to low vitamin levels. We know that low vitamin E, for example, can lead to ataxia. Prior to our more up-to-date diagnostic tools, there were antibodies that were higher than average. And in patients with cerebellar ataxia with an unknown cause, celiac disease was found on biopsy in about 16% of cases, which is pretty high in an unknown group. We think that there may be a direct inflammatory or immune component as well, because there are some limited pathology studies that show the immune system attacking the main cells in the coordination part of the brain. Moving on to neuropathy, that's just a general term for nerve damage, usually in the longest nerves in the body. So it starts in the feet and can progress up into the hands. And so this is nerve injury or irritation that results in numbness, tingling, pain, and or weakness. And there was one study which I thought was very interesting, that not in the celiac clinic, but in a neuropathy clinic, and that there was no other cause found. They looked specifically for celiac disease, and 8% of patients were found to have celiac disease. We usually can see a problem in terms of EMG. That's one of the main tests that we have to look at how fast electricity gets brought across nerves. And in some severe cases, we do nerve biopsies down in the ankle or foot. And about 2/3 of those patients that presented with neuropathy who had celiac disease had some form of reactive antibodies. I think that there's still a lot of debate about whether this is a direct cause of inflammation and celiac disease itself, or malabsorption and a secondary neuropathy because of malabsorption syndromes. Getting to headaches, which is one of the more common reasons why people get referred to me. Almost 1/3 of people with celiac disease reported headaches. It is very common. And in the reverse, in patients with migraine, celiac was found in over 4%, whereas in blood donors, it was found to be about 0.4%. So it is higher incidence of migraines in people with celiac and vice versa. And the good news is that headaches tend to respond quite nicely to going on a gluten-free diet. And I think you've heard that in some of the anecdotes that we've heard today, but this is just more formal. The effect of the gluten-free diet, headache improvement in 77% of patients with celiac disease. So I think that that's very encouraging. A couple rare manifestations, epilepsy or recurrent seizure disorder. In 108 consecutive patients with otherwise unexplained epilepsy, 3.7% had celiac disease. So this is something that we should be looking for in our patients with otherwise unexplained seizures. And so that was true across multiple studies. There is a rare syndrome. It's predominantly in a few families in Italy, Spain and Argentina, where there is celiac disease, epilepsy, and these funny accumulations of calcium in the brain, in the back part of the brain. And so that may give us some clues in terms of why there may be a link between celiac disease and epilepsy. But again, it's something that we look for in the neurology world. Again, the good news is if you go on a gluten-free diet, patients will respond and improve. And is that because we're reducing the inflammation and the direct impact of celiac disease, or are people absorbing their medications better? I think that those are unanswered questions, and it really hasn't been studied well enough to be able to answer that for sure. People ask me all kinds of questions about, well, I have this disorder. Is it related to celiac disease? And there have been multiple studies. I'm just going to summarize them on this slide, but there's really no clear link between celiac disease and Parkinson's disease, another autoimmune disease of the central nervous system, multiple sclerosis, Huntington's disease, which is a rare genetic disorder, but can have issues with transglutaminase, or any other progressive primary brain disorder as far as we know. And so this was a great editorial, and I think that it really highlights that we still don't understand the full link. There's clear link between celiac disease and the nervous system. I hope that I didn't take you into the third group of giraffes that are out there. They're called a kaleidoscope when they're running. I hope you're not running away, and I hope that this didn't take you into a place that's dizzying and full of colors like the other meaning of kaleidoscope. And so in summary, neurological manifestations of celiac disease can be common, but they're commonly not serious or severe. And while there may be many possible neurological complications of untreated celiac disease, most symptoms can be improved or reversed with a strict adherence to a gluten-free diet. And I just want to finish by mentioning that one of my daughters, when she was diagnosed with celiac disease, clearly had some ataxia, but here she caught this fish. She has no ataxia. She had no problems bringing that in and holding it up for this picture. And she's doing great. So this is Abby, by the way. So thank you all very much for your time and attention.
Today, Vincent is 26 years old and lives abroad coaching an international soccer team. He played Division I soccer in college and led his team to compete in the national tournaments. Having celiac disease never fazed him. He says that he felt relief knowing that by simply modifying his diet, he could be healthy and strong and perform at a competitive level. Vincent notes that he hated taking the medications for his headaches, so he found the gluten-free diet to be a much more satisfactory treatment. He admits it wasn't always easy finding gluten-free options on the road, but credits his mom with being a terrific advocate for him along the way. In his own words, quote, "Having celiac disease has felt like no big deal. There were moments I missed things, like at our team spaghetti dinners, but pretty quickly my mom started hosting these events and just made the spaghetti gluten-free for everyone. My teammates were always supportive and felt like a part of my family. I think this had a lot to do with my mom pushing me to be open and honest about having celiac disease. This allowed my team to find easy ways to include me in gatherings. Today, I'm as strong as can be and hope that down the road, I can help other young people with celiac disease realize they can be too."
Great. So we